Welcome to the lecture for Psych 310 Abnormal Psychology. Be talking now about clinical assessment, diagnosis, and then also clinical research. When talking about these things, all three things really, there's some key concepts that'll come up. One will be the distinction between assessment and diagnosis. Assessment is a systematic evaluation and measurement of something, some behavior, some trait, some phenomenon, whatever you're looking at, but it's a systematic evaluation. Whereas diagnosis is a process of determining whether or not some collection of behaviors or some problem meets criteria for a specific disorder. So frequently assessment, the process of an assessment can inform a diagnostic decision, but it won't necessarily. Just because you're doing assessment doesn't mean you'll get a diagnosis. And just because you diagnose somebody doesn't mean you've done a full assessment. You will have had to done some sort of assessment, but not always a complete one. And we can also differentiate between assessment and testing. Testing is just the administration of some testing procedures, giving a test. And testing is a subcomponent of assessment, but they are two different concepts. Okay, so moving on beyond those, key concepts in assessment, some of which we'll see again when talking about diagnoses. Reliability. So when we're talking about assessing, we're talking about measurement, right? So reliability of measurement is about the precision with which you're measuring something. So the degree to which a measurement, a tool for measuring something, is consistent, is precise. So if you think of throwing darts at a dartboard, if you're aiming, or wherever you're aiming, if you hit the same spot every time, then you're being very precise, right? If you get on the scale in your bathroom and it gives you the same weight every time, or just maybe half a pound different, it's precise and it's reliable. You can always, if the thing you're measuring isn't changing, and you're always getting the same measurement back, you have a reliable instrument. Right? Okay, and we can kind of look at reliability from a couple different ways. One would be inter-rater reliability, and not all measurements rely on this type of reliability. But if you're doing kind of some clinical work and we're looking at collecting some behavioral data, you may design an observational measure where maybe you have this checklist of how many times did the subject or subjects exhibit these behaviors, right? And for each behavior, do they do it seldomly, sometimes, or frequently? And so you could go just as one person and observe your subjects and rate them on those behaviors and get some data about the behavior interested in. Inter-rater reliability, to get that number, what you would do is you'd have more than you'd have a couple of raters use the same tool, the same rating scale. So they'd be looking at the same questions, and then they look at the same behavior, and then you compare to say, okay, whenever you said that this person frequently was physically aggressive, did the other raters also say they were frequently aggressive? And if so, if everybody agreed, then your measurement, your process has high inter-rater reliability. A more common type of reliability to be looked at is test-retest reliability. So again, here's this, assuming the thing that you're measuring shouldn't change. Whenever you measure it more than one time, you get the same results back. So from one test to the next, today and 2 weeks from now, the people score the same on your measure of depression, assuming that their depression is stable. If so, your test has high test-retest reliability. Again, that's that precision. And then the third major type of reliability that we look at when thinking about assessment would be internal consistency. So this is whenever your measure is supposed to be looking at one thing. So if you have 20 questions on your measure, some kind of survey measure maybe, and all 20 questions are scored in such a way that it generates one score for how depressed someone is, right? Very depressed, not at all depressed. If your measure has high internal consistency, then all those questions behave the same way. When I say they behave the same way, somebody who looks depressed on one question looks depressed on all the questions. Because each question will be scored to how they answer it to indicate high or low levels of depression. So if you have a highly internally consistent measure, if somebody's really depressed, they're going to score highly on every single question. They won't score high on all but one, and one they'll score real low. If they've scored real low on that one, that question doesn't behave the same way as the others. It might be measuring something else. It might not be measuring depression the same way as other questions are measuring it. And there are statistical ways of estimating levels of internal consistency, which you don't need to concern yourself with now. Just kind of try to understand the concept. Okay. So reliability is important, and it's a prerequisite for good measurement. But we want to go beyond reliability, and the goal in good assessment is to have a valid assessment. So validity is about accuracy of measurement. Does your process measure what it's designed to measure? So if you think of that dartboard again, you could be hitting the same spot every time, but if you're not hitting what you aim at, it's reliable. You're always getting the same result, but you're not hitting the bullseye. It's not accurate. If you weigh yourself on the scale every day, and every day it says that you're 20 pounds, that's very reliable, gives you the same answer every time, but that's probably not valid. You probably don't weigh 20 pounds, I would hope. Okay, and we could spend a lot of time talking about measurement of validity, but we'll just talk a little bit about the two major types. Construct validity, which in some ways is the broad term for validity in general, in terms of are you measuring what you say you're measuring. But we can think of it here in terms of comparing your measurement tool, one measurement tool, to other similar and different tools. So if you have a measure of depression and you give it to a group of people and they all score high on depression, and then you give them another tool that measures depression, maybe the Beck Depression Inventory, one that's well established, and people score high on depression on that too, then your measure has good convergent validity, right? People that look depressed on your measure look depressed on somebody else's, and people that look not depressed on yours look not depressed on somebody else's. If so, you have good convergent validity. Divergent validity would be whenever you compare your measure to another measure that measures something else. So you have your measure of depression, and then you compare how people score on that to somebody else's measure of anxiety. Now there probably will be some overlap between depression and anxiety, but people who are very depressed, they all shouldn't be very anxious. And people who aren't depressed at all, they shouldn't all not be anxious. If that's the case, then you're not measuring depression, you're probably measuring anxiety. So you want your measure to relate to measures that it should relate to, and then you want it to perform differently than measures that it should be different from. Beyond comparing measures to other similar and different measures, we can also look at comparing or looking kind of real world. How does this measure correlate to some observable criterion, some outcome? And we can look at it two ways: predictive validity and concurrent validity. Predictive validity, so I give you a measure of aggression to see how aggressive you are, and you get a score, and I say, wow, you're really aggressive. And then I have you journal for 2 weeks to write about what's going on in your life, and people who scored really high on aggression indicated in their journals the next 2 weeks more instances of getting in physical altercations, right? So I can measure it now to predict some future behavior. Similar to that, just a matter of timing, would be concurrent criterion validity, and that's where I measure your aggression now and then look at how aggressive you are today or actually in the past. So I haven't looked at your past yet, but I give you this measure, and then I look and say, okay, you've been arrested 30 times, and you scored high on aggression on my measure. I have good concurrent validity. So what's your score now, and with what I know about you now and from your past, do those match up in terms of some outcome that's related to what I'm trying to measure? Okay, so we hope that our measurements are reliable and valid, because if they're not, we don't know what kind of information we're getting, right? When you're doing assessment to try to figure out what's going on with somebody in terms of abnormal psychology, if you're using tools that have unknown reliability and validity, unknown psychometric properties, then you can't be sure what the information means, and it's hard to draw any conclusions from your assessment process. And usually, the assessment process has some purpose. You're gathering information for a reason to make some decision, and you can't be real confident in your decision if you're using crappy measures. So it's important for them to be reliable and valid. And then something else that's helpful a lot of times is to use measures that are standardized. And standardization is a process of a couple things. It's establishing specific norms or standards for measuring something, sometimes both. In terms of standardized standards for measuring something, so standardized procedures. So a lot of times there's a standardized when you say there's a standardized measure, we mean when you give the measurement, the tool, when people experience it, everybody experiences it the same way. So when you take the MMPI, everybody gets the same form to look at, and they have to answer the questions in the same order. It's not, okay, well, you can do it this way, but you know what, you can pick every third question to answer, and that's fine. Just whatever you feel like. There's a standardized way to do it. Because usually with standardized tests, you like to be able to make normative comparisons. So that means is you do things in a standardized way, because before the test is used out in the public, the people who develop the test give it to a bunch of participants that are willing to take the test before it's been standardized, and they give it to everybody the same way. So giving people this test this exact way, how did this group of people perform? And once they figure that out, they can figure out, okay, what's the average score on this test? How many people score really high? How many people score really low? And generally, the outcome will follow the normal curve, where for the outcome on the test, there will be kind of this median and mean score, and then most people will be in the middle, and then the tails will spread out from there, where as scores get higher and higher, fewer people will score really high, and as you go to lower and lower from the average, fewer and fewer people score really low. And once you have that normative group to compare to, now when I use the test in public and I give you the test the exact same way, I can compare your score to that normative sample. And I can say, okay, you got 20 out of 25 right. And depending on how the normative sample did, that might be average. You might be right in the middle. Or that might be above average and you did really well. Or it might be really below average and you did really poorly. Almost everybody in the normative sample got 24 out of 25. I don't know, but you have that data to compare it to, and so you don't have to give the test to everybody again. You keep that one set of normative data for all future test purposes. And then, of course, good test makers will re-standardize every 5 to 10 years to keep things updated. Okay, so we've reviewed some of the key concepts in assessment, some of which will also apply to diagnostic procedures. So we kind of have some inkling, some idea of what we're talking about here. But before we go further into the specific procedures, we need to think about why do we assess at all? And that's not why asses. Everybody always thinks that when I do this in class, not why asses, why assess. So why do you think for abnormal behavior, why do psychologists, psychiatrists, counselors, when would they use assessment procedures? When would they be gathering information about behaviors and cognitions and emotions? Well, typically to make some predictions and or decisions. That makes sense. Well, like what? Well, like a lot of things. Could be trying to make a decision about, okay, these two people were married, they had kids, and they decided to get a divorce. And now we need to figure out what should happen with the kid. Should the kid live just with one parent, or just with the other, or with both? Right? And a judge typically makes that decision if the family can't make it themselves, if they contest custody. But whenever that happens, invariably the judge will ask for an assessment by a psychologist, usually, to gather data from both parents and from the child to make some recommendation about what's in the best interest of the child. And so they have to collect data They have to assess the behavior and cognitions and feelings of all the people involved and come up with some suggestion. If somebody is in prison and they're trying to determine what level of security they need to be at. Do they need to be in solitary confinement? Can they be in general population? Can they be a trustee where they can be let out? Usually there's some psychological assessment going on there too that helps inform that decision or those decisions. Even life and death decisions in terms of if somebody commits a heinous crime and is scheduled to be executed, well, if they're deemed, well, depending on the state, if they're mentally retarded, in some states they can't be executed. And to make the determination of mental retardation, to make that diagnosis, you have to have assessment, lots and lots of assessment. Even before that, before somebody can be tried, sometimes you have to establish that they are sane. Not that they were sane or insane whenever they committed the crime, but are they sane now in order to understand the procedures that they're going to go through to be tried. And that involves assessment. So there's all kinds of decisions, those really life and death ones, big ones. Where's your kid going to live? There's even more mundane stuff in terms of if you're working for a corporation and you're trying to advance on the kind of a managerial track. Frequently, these corporations employ psychologists to develop and conduct assessments to determine if people are management material, right? Even before that, whenever maybe you're trying to figure out what career field to go in, you may undergo some assessment to figure out your career interests and aptitudes. So there's all kinds of decisions and predictions that can be made based on assessment procedures that are conducted by psychologists and other mental health professionals. For abnormal behavior, there's a wide range, including those things about prison and child custody. But a lot of times what we think mostly about are treatment planning, right? So trying to figure out, well, would this person respond to talk therapy or not? If they're a poor candidate for talk therapy, then we're not even going to try it. We'll just use probably some medical therapy, drugs, or possibly surgery, usually drugs. And then there's some assessment that might inform what type of treatment might be most effective, most beneficial for a person. So trying to figure out what path to take when starting out treatment, assessment's involved. But beyond that, assessment shouldn't kind of be a front-end thing only. Assessment can also be used to evaluate treatment at the end of treatment. So once the treatment's done, are you better than when you came in? Well, to know, we have to collect data. We have to assess. And really, if you're a skilled clinician, you'll do assessment throughout. So are you getting better now? Okay, a week later, are you getting better or are you worse? What things are getting better? What things are getting worse? And trying to figure out why they're getting better or why they're getting worse to maintain the gains and limit the losses. So assessment is a continuous part of treatment as well as these other major decisions. Okay, there are several ways to gather data in terms of assessment of clients. And these are just a few. Clinical interview, physical exam, observational procedures, psychological tests, client records, and we'll talk about a couple of these. Let's start off with clinical interviews. They can vary in the degree to which they're structured. You have structured, semi-structured, and unstructured. Obviously, a structured interview, you have a set number of questions that you ask. And usually with a fully structured interview, you ask a question, and depending on their answer, you have this decision tree. Okay, if they say this, then you ask this question. If they say, if they say yes, go here. If they say no, go here to this question. Right? So it's kind of this prescribed set of questions to arrive at some decision. Sometimes a diagnostic decision, like, okay, they said yes, yes, no, no, yes, yes, no. That branching leads to, okay, they have major depressive disorder. Right? Other times, it's used for other decisions, looking at just yes, they have a severe problem. No, they don't have a severe problem. But it's a very structured process. Doesn't take a whole lot of skill to do that because, again, you have the questions there for you. A step back from that would be semi-structured interviews, where you have usually certain areas. Okay, you need to ask about this. So you need to ask about drug and alcohol problems. You need to ask about family of origin. You need to ask about current coping behaviors. So you have certain things you're going to ask about, but you have freedom to then follow up on things, right? So when they answer, you don't have to go, okay, they said this, now I go here. You just have to cover these areas. So there's some structure, but it's not fully structured. And then obviously the least structured would be unstructured, and that's where you ask whatever you want. And usually, most clinicians use somewhere between semi-structured and unstructured. And by say somewhere in between, it's semi-structured in the sense that most therapists have certain things that they know they're going to ask about, but it's not something that they, a test interview thing they bought somewhere that says, okay, make sure to ask this and this and this. There's certain things that therapists know. Okay, I want to ask about this. I want to ask about this, and what they want to ask about will differ across therapists and people with different theoretical orientations. One thing to be aware of is that when doing clinical interviews, a lot of people think, okay, well, you're asking questions, you're getting information back, so you're getting content. Yeah, and the content is often important. But what's also important is that you're able to observe process. And by process, you get to see what they're doing while they're answering. So I've asked, okay, tell me about your childhood. What are some significant early memories? And they say, I really don't remember much. Somebody says, I really don't remember much, and then pauses and looks confused. Okay, that might mean one thing. Somebody else that says, I don't remember much, crosses their arms and glares at you. That means something else, right? So the same content, two different processes, said different ways. There's different things going on with those two different individuals. And you wouldn't get that from other ways of assessment. So that's one of the advantages of interviews, is that you're able to look at process. So let's look at some other the pros, the advantages of clinical interviews. Lots of flexibility, especially if you are using a semi-structured or unstructured interview. You can probe more or less. So compare this to think about a paper and pencil questionnaire that you give to somebody and they fill it out. With that, they fill it out, and whatever they write is what they write. With an interview, you ask a question and they give an answer, and now you can decide, I want to follow up on that, or no, I don't. So using your clinical expertise, you can get a lot of information without having to ask about every single thing. Because you might say, okay, I asked this one question, they answered, okay, everything in that area, there's no concern, I'm moving on. I'm not going to waste my time asking a bunch of questions about that. But no, okay, about this, ooh, that was interesting. I'm going to go deeper here and ask more questions about family of origin, or about your current romantic relationship, or whatever it is that they're getting some information back about that indicates there's an area that needs further assessment. So there's a flexibility there. You get nonverbal information, right? So when somebody's filling out, again, a paper and pencil test, if you're really, really clever, you might be able to tell if they push down hard on the pencil or not, but most of us can't figure that out. But when we're talking to people, if you're, again, a trained observer of human behavior, you're going to pick up on some indicators of mood, of experience of emotions, possibly of cognitive processes, from watching them interact with you. And especially information about their interpersonal style. You get a lot of stuff by being in the room with somebody, more than you might be able to get asking them questions in a pencil and paper format or other modes of assessment. So nonverbal information, and like I said before, just lots and lots of information in terms of both content and process. As much time as you're willing to spend, you can get an enormous amount of information from people. Again, but both that content and that process. So clinical interviews are usually a part of all clinicians' assessment when we're working with clients who present with some sort of abnormal behavior. So it's an important piece. But it's not the only piece, and it can't be the only piece because it has some limitations. One, the subject, the client, might be unable or unwilling to give accurate information. So usually we think about the unwilling, so they might lie to you. Okay, so have you ever used drugs? Nope. Right? Because they don't want to tell you, because maybe they're there trying to they have to do a psych eval to qualify for a job as a police officer. So if they're smart, they'll tell you that no, they've never done drugs. Because if they tell you that, they're not going to get the job. But so they might be unwilling to give accurate information about certain things. They might lie, but they also might be unable to give accurate information. So when you ask about, what was what were your parents like growing up? Whenever they tell you the answer, that may not be an accurate representation of what their parents were like. It may be an accurate representation of what they remember and what they perceive, but that any kind of memory might be distorted by things that have gone on since then. And not that they're purposely doing it, but we're not, we don't have DVRs in our brains where we can record stuff automatically and then spit it back out. We record the gist usually of stuff, and then we bring it back out through filters of experience and expectations and settings and all this other stuff to come up with some sort of thing that's usually not some memory that isn't exactly the same as what happened. So the information won't always be 100% accurate, so you have to be a bit skeptical sometimes about the information you're getting. There's a subjectivity in terms of interpreting the data that you get from the interview, especially the process stuff and the nonverbals. Somebody's crossing their arms. Maybe they're mad. Maybe they're feeling threatened. Maybe they're cold. Right. So there's a certain level of interpretation here that is a bit more subjective than a paper and pencil test. We're asking people, how many times in the last month have you had a drink? 1, 2, 3, 4, 5. Right, that's much more objective. There's a number. Versus, I perceive this person seems to be struggling with alcohol because when I asked about it, they paused quite a bit. And so there's a subjectivity there frequently in the interpretation of data that you get in clinical interviews, which, at least the next kind of last drawback, is that the quality of information is really dependent on the skill of the interviewer. And the skill of the interviewer not just in interpreting the information, but in getting the information. If you've ever seen a really bad interview, you'll know it's bad. Because if you don't establish rapport with somebody and make them feel comfortable, they're not going to give you information, and it's going to be a painful process of question, answer, question, answer, question, answer, with no elaboration and nothing really going on in the session besides kind of yes/no stuff. So good interviewers can get more information, and good interviewers can usually make more sense out of the information that they're obtaining. Okay. So some pros and some cons. But again, one of the most widely used procedures for collecting data for the assessment of behavior when working with clients presenting with abnormal behavior. Moving to something that's maybe more objective, depending on how you do it, observational procedures. So instead of just asking people about themselves, observing them, getting observational data about them. So now we're not relying so much on memory, and that we're getting around that unwillingness, inability to share information. So observational procedures can be more or less formal. Right, so you can have kind of this observational coding sheet where you're looking for certain things and you're marking exactly, okay, during every 5-minute interval, check the box if this behavior was present, and don't check if the behavior was absent. Right? Or it can be more informal, where you're going to do an observation on a kid in the classroom, and you go in with a blank piece of paper and a pencil, and you take some notes on what you see. Right? So, and anywhere in between can occur as well. One thing that you're frequently looking for, whatever observational procedure you use, and this has to do with kind of the roots of behaviorism, is this pattern of antecedent behavior consequence. And so usually when we're talking about abnormal behavior, there's some problematic behavior that we're asked to make an assessment about. So that behavior is the thing we're interested in, right? But we don't just observe, okay, did the behavior happen, yes or no? Because if it wasn't happening, they wouldn't be asking for assessment. So we know it happens. We want to know why it's happening. And one of the assumptions of behaviorism is that behavior is functional, that it happens for a reason. It's doing something for you, and we need to figure out what that is. So to figure that out, we look at the pattern of, okay, what happened right before the behavior, and then what happened after it. So is the behavior a response to something? Is there some cue that's causing this behavior, or is there maybe some consequence that's causing this behavior, maybe a reward that's making this behavior more likely to happen? Or maybe you're punished when not exhibiting that behavior. So we look for that pattern to try to figure out what the function of the behavior is. One thing you can use when doing observational procedures would be rating scales. And this is just kind of thinking about a bunch of behaviors before you go in, and then rating the frequency that they happen. Seldom, sometimes, very often, however you want to do it. Another thing, we often think of going in and observing others, but in addition to kind of other observation, frequently clinicians rely on self-observation. And this isn't the same thing as just asking people, okay, how many times did you do something this week? It's giving people the task of, over the course of this week, I want you to keep track of. And here's a little notebook, and here's a pencil. Keep it with you at all times. And whenever you do this thing, note it in your book, which can be a helpful procedure for gathering data, but also for treatment. So things like trichotillomania, which is a hair pulling. People pull the hair out. Sometimes they eat it, get the bezoars in their stomach, hairballs. Causes some problems. It's a habit behavior, not anything real severe, but can cause some problems if left untreated. And one of the ways to treat trichotillomania is to assign some self-monitoring, some self-observation homework. Because once you pay attention to yourself pulling your hair out and have to keep track of it, you do it less, right? Observing our own behavior changes our behavior, and especially habit, kind of mindless behavior. If we're assigned a task to pay attention to what we're doing, we don't do those mindless things quite so much. So in terms of the pros of observational procedures, you can get some very detailed information. So if maybe there's a kid who's being aggressive in school, and you can ask the kid about it, and they can maybe tell you some stuff. You can ask the parents and the teacher, oh yeah, they push sometimes. But that's usually about as much as you're going to get. If you go and you observe them, you're going to get a lot richer, more detailed information about exactly what's happening when they're aggressive and what's happening when they're not aggressive, at a level that you can't get without being there firsthand. And also you can get unique information, especially for self-monitoring observation. So behaviors that other people can't see for certain reasons, sometimes because the people are embarrassed or ashamed of their behaviors. So when trying to figure out how often someone with an eating disorder is engaging in binging and purging, if you try to watch them, you're not going to see them do that because they'll do it in private. You try to ask their friends, family, how often they do it. They might have some guesses, but they don't really know, because again, it's something that's usually done in private. But if you can build trust enough with a client to get them to record when they do it and share that with you, you're going to get much more accurate information that you couldn't really get any other way. So some information that's unique in terms of you can't get it through other methods. Cons. Sometimes it can be difficult to get. If you're a busy clinician, kind of real world, it's much faster to give somebody a paper and pencil measure, or even do an interview in an hour, 2 hours, than to drive to their school or work or home and watch them for however long it takes, and then process all that data, or having maybe to set up video cameras and reviewing the tapes, and it can be fairly time intensive and resource intensive to get good observational data. So it's more often done for research than in clinical settings, with the exception being with kids. With kids, we do more observation because they're easier to observe. We can go into a school pretty easily and observe kids. It's harder to go into drive down to Dell and watch somebody in their cubicle. That gets a little awkward. They don't really let us do that. Another common would be reactivity, which again is good in some ways and bad. For treating trichotillomania, it's good that there's reactivity. Reactivity is that behavior changes in response to being observed. And sometimes that's good. But it's bad whenever it doesn't give us accurate information about the behavior, and then when we stop observing, the behavior returns. So every time we go look for it, there's no behavior because the person's reacting, and they're not going to exhibit it when we're watching. If they can maintain the absence of behavior, then good, it's a treatment. But if it comes back as soon as we stop looking, it's not an effective treatment, and we never got a good idea of how much they were doing it or why they were doing it, and the antecedents and the consequences. The other thing, obviously, for the self-report behavior or other observation, if you're having a parent or a partner observe somebody, there is the potential for biased reporting. And bias, not necessarily in terms of like negative, harmful bias, like they're trying to make them look bad or trying to make them look good. Just that people see things differently. And when we ask two parents to report to keep track of how often a kid does some behavior, they will come back with very different pictures. And that may be because the parent, how many times is the kid aggressive? And maybe there's an instance where the kid bumps into another kid. And one parent says it was aggression. The other parent thinks, oh, they were being clumsy, and so they don't see it as aggression. There's a difference in the perception of the behavior, and because of some bias, some difference. But it also may be sometimes people will be different for one observer than for another. So we have to make sense of those discrepancies if we gather information from multiple reports. If you don't gather information from multiple reports, then you're not going to have any idea about the level of bias, or if there are, how accurate it is. Unless, again, you can get some very detailed information, which is nice. Okay, if we look at psychological tests, lots of different types of tests. We won't talk about them all. Talk about a few personality inventories. These are whenever you're answering questions about yourself, right? And they're standardized, so it's the same questions for everyone. And there's a data set regarding what the typical answers are. This is a normative data set. So basically, it's a standardized self-description. And most of the big ones assess personality, characteristics, traits in some way, shape, or form, and they also provide some data regarding psychopathology. So people that answered questions in this way, this is indicative of, or this is similar to how people who have these diagnostic labels. If that makes sense. Two of the biggest ones, the two big ones out there right now, the MMPI-2 and the PAI, Minnesota Multiphasic Personality Inventory, second edition, and the PAI is the Personality Assessment Inventory. Both long tests, a couple hundred questions. From MPI, maybe a little bit longer than the PAI. Both have lots of research supporting them. The advantages of using tools like these, you can measure a wide range of behavior. If you're asking somebody 262 questions, you can cover a lot of ground, which is helpful, especially as a starting point. Somebody comes in and they're maybe presenting with, they're complaining of, I've got this problem. I'm anxious here. And if you only followed that and said, let's talk about your anxiety, you might miss other stuff. So you give them this assessment, and they show up anxious, but they also show up, scoring high on some measure of psychotic experiences. Oh, maybe you're anxious because you're hearing voices. You didn't mention that. It's like, the voices told me not to. Huh, okay. But again, things that maybe you wouldn't think to ask about. you may get on these kind of wide net tools. The other thing, you can use, the actuarial interpretation, and that's using those standardized norms. So things like T-scores. You may be familiar, hopefully you're familiar if you're taking stats, with Z-scores, right? So if you're perfectly average, you have a Z-score of 0. If you're 1 standard deviation above the mean, you have a Z-score of 1. If you're 1 standard deviation below the mean, a Z-score of -1. T-scores are the same thing, just with the average at 50 instead of 0, and the standard deviation is 10. So 60 is 1 standard deviation above the mean. 40 would be 1 below the mean. And usually in clinical settings, we think things are concerning, of clinical interest when they're above 65 T. So about 1.5, sometimes 1.5, sometimes 2 standard deviations above the mean, depending on which subscale we're looking at. If you score that high, it's important. So if you're slightly above average, not that big a deal. If you're low, usually on measures of psychopathology, usually we don't overly interpret those. The only thing we might think when you're super low is you're lying, because most everybody has some level of these measures of psychopathology, like some level of anxiety, some level of depression. If you answer no to all questions about every experience of sadness, and you're down at like 10 T on the measure of depression, what's going on? Why aren't you willing to admit to ever being depressed? Or are you the happiest person in the world? And if you are, why are you in my office? But again, using these standardized tools lets you take use of the data and make actuarial interpretations in terms of, okay, you're this far above the mean. That means that only 10%, only 5% of people scored above you, or maybe only 20% scored below you. Wherever you fall, we can know what percentage of people in the standardization sample scored above or below you. And depending on what test you look at, you might even have different normative groups to compare to. Like with the PAI, you can say, okay, here's where you fell, and you're perfectly normal for the normal population, the non-client population. But for people who present to psychology clinics with a problem, you're really low. Okay, and that might be meaningful. So, okay, you're normal for most people, but this is low for somebody coming into a clinic. Maybe you're denying stuff. Most people who come into the clinic are reporting more problems than you're willing to report. What's going on there? And you can get that from these measures. The other thing that's really helpful is they include validity scales. And validity scales aren't perfect, but they can give you some information about how people are answering. If people are trying to look really bad, usually these validity scales can pick up on it. So there are certain questions embedded in the measure that if you answer them a certain way, we kind of know, oh, you're trying to look really really bad, because in the normative sample, nobody said that. So they have a question there that almost every single day I have nightmares about being stabbed, and I wake up feeling like I'm covered in blood. Right? If you endorse that, probably very few people have endorsed that. That might be a lie item. So we're going to kind of wonder, oh, well, you're trying to look bad, you're trying to fake bad for some reason, and there are lots of reasons to fake bad, right? Maybe you're in some workman's comp thing, maybe you're in the prison system and you're trying to get into a psych ward, which would be a better situation for you than the cell that you're in. Different reasons for trying to fake bad. They can also catch you for trying to fake good, right? If you don't admit to any shortcomings, the test goes, most people don't. Most people will acknowledge experiencing some anxiety. You don't have any. Or there may be something there saying, I read the editorial of the paper every single day. And you say, yes, very true. Nobody does that. If you say that, you're trying to look good, and the validity scales will pick up on that. So that's nice. For the negatives, the downside, a person's performance is dependent on their cognitive ability. So people that are low functioning cognitively, you can't get much information on this test. If you can't read, there are audio tape versions, but you still have to be able to understand the vocabulary that's used. And usually these things are written at about they say they're written at about a 4th grade level of vocabulary, but that's not always the case. And if people don't understand the words in the questions, then they won't be responding to them appropriately. In the data you get, not going to be clear. Then the other thing, we talked how nice it is to have those validity scales. But if your validity scales say the profile is invalid, this person was faking, well then what? Okay, so you were trying to look worse than you are, but I don't know how bad you really are. Or you're trying to look better than you are, but I don't really know how bad you are. So there's a limitation there. So the validity is good for catching faking, but then what? How do I correct for the faking? Well, you go back and you do more testing, is the short answer. Okay, other types of psychological tests, symptom checklists. These are things that are problem-specific measures of thoughts, feelings, and behaviors. Things like I feel sad much of the time. Never true, sometimes true, always true. And it'll be so if I had a symptom checklist for depression, I would have that item. Some examples: the Beck Depression Inventory 2 is obviously a depression inventory. The EDI, Eating Disorders Inventory. The Y box is the Yale-Brown Obsessive Compulsive Scale. So they have these personality and psychopathology measures. The PI and MPI ask about all this stuff. Then you have these smaller measures, they're usually 20, 30, sometimes 10 questions that focus just on one area of functioning. Maybe just on depression, just on anxiety, just on eating behaviors, just on obsessions and compulsions, whatever the person maybe is presenting with. So these are more focused tools. Oftentimes you'll use this if somebody comes in presenting what they say, I have concerns about obsessions and compulsions. You may give them the PI to look at everything, but you're also going to give them the Y box because it looks more closely at the OCD stuff, right? The PI will have some questions on it, but the Y box might have more focused questions on obsessions and compulsions. The other thing is nice because it's short. You can use it frequently. You can use these things frequently over the course of treatment, right? So you can give somebody the BDI, Beck Depression Inventory, when they come in, and then you can give it 2 weeks into treatment, 4 weeks, 6 weeks, 8 weeks, and you can track their level of symptoms. Is it getting? Are they getting worse? Are they getting better? Harder to do that with those big personality inventories that take an hour, hour and a half, 2 hours sometimes. To complete. Most of these things people can knock out in 15 minutes. So something at the end of the session, fill this out, or right before you meet, you're in the waiting room, fill this out, and then I can talk to you about it in the course of the session. Okay, another kind of group of tests, intelligence tests, which measure, they're not measures of intelligence necessarily. A better term would be measures of cognitive abilities, which they do play a role in abnormal behavior. Primarily when thinking about kind of the assessment towards the diagnosis of mental retardation, right? Because part of the diagnostic criteria for mental retardation is an IQ, a score on an IQ test below 70, right? That's part of the criteria, so it's important for that. But also, there's some other disorders that involve disrupted cognition, so, psychotic disorders, where you think differently, where you might pick up on some of that using intelligence tests. Think about people experiencing dementia, kind of these cognitive declines. Intelligence tests used for that. Autistic spectrum disorders. Intelligence tests important in figuring out what's going on and where you are on the spectrum, and if it is really spectrum stuff, or if it maybe is more mental retardation stuff going on. Some examples, the big ones, the WISC and the WACE are both Wechsler's tests. The WISC is the child version, the WACE is the adult, and then the Woodcock-Johnson is a different test by a different author that covers children to adults. The good things about these tests, they're very heavily researched. There's a lot of data out there about what scores on these tests mean. So if you score high on this test or on this subcomponent of this test, it correlates with this, 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 and this. All these things, because the test, and so they know some stuff from the normative sample. But beyond that, people have been researching these things for so long. We know quite a lot about people who score high or low on the different subtests of these tests and what it might indicate. The other thing is, beyond what you may think, these intelligence tests, IQ tests, don't just give you an IQ score. Frequently, the IQ score, which they usually do give you one full-scale score, isn't the most interesting thing. All of them now give you, okay, for this part of cognition, for your short-term memory abilities, for how quickly you process information, for how quickly you process verbal information. They give you different scores for all those different pieces of cognition. Because it's not just, oh, you're smart, you're dumb, right? People think differently. So where are somebody's strengths? Where are their weaknesses? And then you can think about, okay, this pattern of strengths and weaknesses, how does this correspond? How might this help explain this pattern of abnormal behavior? And that's where it gets really interesting. Pretty cool stuff. But the cons, there is potential for misinterpretation, especially when people think about that we're really accurately measuring this thing called intelligence. Intelligence is a construct. It's a concept. You can't touch it or feel it or smell it, and nobody can even agree on exactly what it is. But these tests, we call them intelligence tests, but again, they're better termed measures of cognitive ability, because that's what they do. Until we can agree on what intelligence is, it's silly to say that we're measuring it. Nonetheless, all of them generate a full-scale score, and people use that to say, okay, you're intelligent or you're not, which is a misunderstanding, misapplication of the test, but that's there. The other potential negative would be the relevance of normative comparison, and this is about on an individual basis, and it holds true for other tests as well, but has been really problematic with IQ tests for some reason. If you're a recent immigrant from the Philippines, and you score high or low, wherever you score on this test, high or low is relative to the normative group. If the normative group are all, fifth generation Americans who all speak perfect English, what does your score mean? Okay, so we know how many questions you got right compared to this group. Does that provide us any information about your cognitive abilities or not? So, how relevant are the normative comparisons depends on how well that person matches the comparison group. Okay, now for the cool tests, right? The projective tests that come out of psychodynamic theory. So for projective tests, clients respond to ambiguous stimuli. The theory behind this is that abnormal behavior is the product of these unconscious conflicts or unconscious drives, depending on which theory, which psychodynamic theory we're talking about. But something's going on below the surface that you're not aware of. So these other assessment procedures, the psychodynamic people would argue, aren't going to get any answers because you don't know why you're doing what you're doing. You don't know that you hate your father, and that's why you're so competitive at work and fighting with all the other men you work with. You're unaware of that. So the thinking is they can figure that out. They can get to that information. They can get to that unconscious conflict by presenting you with this ambiguous stimuli and having you just kind of respond to it. And when you respond to it, they'll be looking for the conflicts, and they'll be able to see pieces of evidence of the conflict, that it'll rise up, it'll bubble up from the unconscious to the conscious when you're presented with something that doesn't have a clear right or wrong answer. One of the most famous projective tests would be obviously the Rorschach ink blot test. Okay, so tell me what you see, and then you start writing down what they say. And there are lots of ways to give the Rorschach and to score the Rorschach. The Exner method is one of the most popular. And when you do that, it's not just tell me what you see, and they say one thing and you're done. You have them generate as many responses as they can, and you're scoring them on a lot of stuff. It's not just, oh, interesting, you said this, that means this. It's, okay, how did they use the blot? Did they talk about the color, they talk about the white space, talk about the black space. What type of content did they see? Did they see people? Were the people interacting? Was there movement? Was there not movement? How many responses did they come up with? There's all this stuff that you then you enter into these very complex formulas to come up with some clues about how this person is making sense of their world. But you can also use it to think about kind of presence of archetypes in their answers, and the use of defense mechanisms, and other psychodynamic stuff. But again, there's no right or wrong answer to these things. You're just trying to figure out what's the stuff that's under the surface. Another approach, the thematic apperception test, where you show these story cards, right? And you say, okay, tell me a story with a beginning, a middle, and the end. Tell me what the people are thinking. Tell me what the people are feeling. And the idea being, okay, well, it's not clear what's going on in the story, so whatever they say will be not so much about the picture, but it'll be about them. So they say that this guy is tired. They see that he is sad. Did he just kill this woman? Is there aggression? Is there some sexual content? Are there things they're ignoring? Like, so do they not talk about the woman at all? Because she's obviously clearly an important part of the picture. So are they avoiding certain things? And you can get some information about how they're thinking and what maybe is going on behind the scenes, in the unconscious. So fun test to give. Advantages of projective tests. Really hard to fake. Hard to fake because there's not a right answer, right? Whenever you ask people, do you use drugs? The right answer is no, right? For tell me what you see, there's not a right answer. And if you try to come up with the right answer, they're going to see that, right? Because they'll see that, okay, they're being defensive, they're ignoring this stimuli, and they're only giving one answer. Different things. Another advantage is, again, beyond the content, especially for psychodynamic-oriented evaluators, you're looking at the process. How are they during the assessment? So, do they seem anxious? Do they seem at ease? Do they maintain eye contact with you? Do they look away? Do they need to ask for a break? What's going on over the course of responding to these stimuli? What are kind of the emotional indicators that you're picking up on as they're responding to stuff? But there are some pretty significant drawbacks. One, the reliability and validity of the use of these measures is fairly questionable. It really depends on how you do it. Because like for the Rorschach, the ink blots they're the same ink blots for everybody, but how you use those ink blots can differ substantially across the There's not one standardized way to do it. Like I said, the Exner system is one way to go, but there are other ways to go. And depending on which way you use, some ways of using these materials have more support for their reliability and validity than others. The other drawback, it takes a lot of time to administer and to score these things, and a certain level of expertise. Projective tests, that's one of the areas that in the kind of the turf battle among mental health professionals, psychologists and psychiatrists kind of carved out and said that you have to have a PhD to give these things. I'm not sure why, but well, it's about money. But you have to have a certain level of expertise, and it does require some training to administer and interpret these things appropriately. So for assessment, I'd say overall, they're not ideal. They certainly wouldn't be ideal for assessment towards diagnosis. That being said, assessment for gathering information about your client, I find them very useful, and I think they also potentially be very therapeutic, because if you're using them in therapy, then you're not worried about doing things standardized, and as they're telling a story, you can interject questions. So the man is horribly sad. He's grief-stricken over what he's done. And if you have a client who you know is feeling guilty about something, you can ask them, okay, so is this you in the picture? And then you can maybe connect to some feelings that they haven't been able to talk about before. And you kind of get this doorway or this window into emotional and cognitive content that maybe you couldn't get without this process, these projective tests. So I find them helpful in therapy. Their utility in the assessment towards a diagnosis, a little less clear. Okay, what about psychophysiological assessment? So kind of some physical exam stuff and using measures of not what they do or say, but what their body is doing, right? So we can look at some interesting stuff more now than before. But usually this involves measuring mostly autonomic nervous system functioning, with the idea being that these things are physical manifestations of psychological processes, right? So when we're measuring GSR, right, galvanic skin response, heart rate, respiration rate, EEG, the thinking is that, okay, whenever your heart is going up, whenever you're breathing faster, whenever you're sweating more, that indicates this psychological process. And the psychological process is usually what we're interested in. We're not interested in, okay, we need to reduce your heart rate, and that's our target intervention. We're trying to make you less anxious, right? So with the assumption being that these physical markers correspond to the psychological process. So advantages of this, these types of tools, they're less subject to voluntary control. So again, this is kind of harder to fake, being the idea. So if somebody who says that they're not anxious, but their heart rate's going a mile a minute, their breathing's fast, GSR is off the charts, yeah, you're anxious. And you can fake, so you can lower your heart rate. If you're typically really anxious, but you don't want to look anxious during this assessment, you can do things to control your psychophysiological responses. Some of them medical, others not. I mean, you can use your ninja kung fu and just calm and relax. And some people are better at this than others at controlling their autonomic nervous system. But it is possible, but it's difficult to control. It takes a lot of training to do those types of things. So harder to fake, still possible. We can get some unique information. Sometimes people maybe don't realize they're anxious, but we hook them up to some measures. And wow, your muscles are super tense right now, and your body is acting like somebody who's very, very stressed, and they have no kind of cognitive awareness of that. They're not connected to how stressed their body is feeling, and that can be important. The negatives, drawbacks, electrodes tend to freak people out. So in a clinical setting, hooking people up to a lot of equipment can be off-putting for people, and it can also distort your data. People can look more anxious when doing this because it's anxiety-provoking being hooked up to all the stuff. The other thing, there's a low correlation among autonomic nervous system measures. So somebody who we think, okay, well, high heart rate and high respiration rate both indicate anxiety, but there's not a high correlation between those things in people. So if they're not highly correlated, are they both measuring anxiety, or are they measuring different parts of anxiety? Not sure, which leads to kind of the biggest thing. The results are a bit ambiguous, because there's not a one-to-one correspondence between the autonomic nervous system and the psychological process, right? When your heart rate's high, it doesn't necessarily mean you're anxious. It generally means you're aroused, but it's at that level. Aroused, is it aroused anxious, aroused angry, aroused sexually? Aroused, and that's kind of all we know from these things. And it's harder to kind of get at the finer points of affect and mood states from these measurements. They're a bit clumsy, a bit vague. Another approach related to that would be neuropsych testing. And this isn't the brain scan stuff. Yeah, we'll get there. This is trying to look at how the brain's working, usually looking for brain dysfunction by looking at its effects on a person's ability to do certain tasks. So we're going to give you these tasks, and if you can't do certain things, we think, okay, that means that there's damage to the brain in this area, because we know that usually from previous studies, people that have a tumor here or have this part of the brain cut out can't do this. They can count to 10 forwards, but they can't count backwards. When that happens, it's usually this area of the brain that's damaged. Right? So that's what neuropsych testing is usually about. Some examples: you have the Luria, Nebraska neuropsych battery, the Halstead-Reiten, two of the big ones. Advantages compared to surgery, very non-invasive. So if you're trying to figure out where a tumor might be or where a stroke might have occurred, you don't have to crack your skull. If we can give you a test and figure that out, and not kind of dig around until we find the tumor, that would be nice. So non-invasive. Again, we also get unique information. Sometimes there's things you can discover with neuropsych testing that you just wouldn't have gotten any other way, because often whenever there's brain damage, the person doesn't know that something is off, right? And if maybe they're not able to recognize emotional expressions in other people, they may not know that they can't recognize certain emotional expressions, but the neuropsych testing might pick up on something like that. The cons, kind of like projectives, lots of time, but unlike projectives, lots of money as well. It's expensive. Frequently to get the stuff done, and your insurance may or may not pay for it. But it's very good, but they know it's good, so it costs. And then there's also a significant cost of false positives and false negatives. So if they say, okay, you have brain damage in this area, we're going to start radiation right away, but you didn't have a tumor there, that having your brain radiated for no reason, not necessarily a good thing. And also a false negative. They say, okay, well, we didn't find anything, but there really was something there. This is kind of high stakes stuff when we're talking about brain dysfunction. Okay. The brain scan stuff is what we're getting to now. So neuroimaging techniques. We have a couple different ways of doing it. We can look at the structure of the brain, things like CAT scan, an MRI. This is a picture here looking at the difference in ventricle size, which the ventricle is just a space in the brain that's found sometimes when comparing people with schizophrenia to people without schizophrenia. People with schizophrenia having enlarged ventricles, so a bigger space in their brain, indicating smaller or less brain matter in a certain area. We can more interesting than that, really, because with the structure of the brain, we can only see so much, and we can only figure out so much, usually by destroying parts of the brain. But the kind of really cool new stuff is looking at the function of the brain. So PET scan and functional MRI, saying what parts of the brain are working during different activities, or are certain parts of the brain more active or less active in people that have that exhibit certain behaviors. Right? So if you have OCD, is there a certain part of your brain that's more active than somebody who doesn't have OCD? And we can do that with these cool ways. Looking at where the cells in the brain are using energy, are using up glucose usually. So PET scans, functional MRIs. So take it now. It's kind of like picture for the functional MRI. Advantages of these things: you can find tumors and disease, and that's important, very important. So beyond identifying brain differences between people with diagnoses and without, sometimes abnormal behavior is caused by an identifiable tumor or disease. Rarely, we always, for a long time, we thought, oh, we're going to find, once we figure out this brain science, we're going to find these tumors or these disease processes that clearly correspond to these behavioral patterns. Hadn't really happened, but sometimes it does, and sometimes it's treatable, and that's nice. Also, it's just kind of interesting that we've found some relation between brain activity and behavior. Unfortunately, it's not this kind of easy, clear, one-to-one relation where we can look at a brain scan and then, so we know what the person is doing or thinking by looking at these pictures. Maybe one day, but we're not there yet. The drawbacks, there's no norms. And this is something that should be coming soon. But we don't know. Okay, so we have a picture of your brain, and we know generally where things are supposed to go. But in terms of how much your amygdala should light up when talking about your job, we don't know, because we haven't given functional MRIs to enough people while doing that task to get a normal picture. Most people that get these scans done have something wrong with them, right? So there aren't a lot of normal people without asymptomatic people getting brain scans. And part of the reason for that, part of the reason there aren't norms is it's expensive. Thousands of dollars each for these scans, because the machines are expensive, and then the interventional radiologists also, or not intervention, but the radiologists also well paid. The other thing, there's mixed evidence for localization, and localization has to do with that correspondence between brain activity and behavior, with the idea that, okay, this part of the brain is responsible for this behavior or this feeling or this thought. Some studies we find that to be true, but more often than not, once we find that, okay, well, this part of the brain is involved in this, some other studies will say, well, yeah, but not really, not in this person. And again, until we have really comprehensive norms, we won't have a good idea about the extent to which localization is true, where certain behaviors or thoughts or feelings are localized in one or a few areas of the brain. Okay. So we have all these kind of complicated approaches to gathering data, but probably one of the simplest, one that everybody relies on, would be a review of client records, health records, education, employment, criminal, especially previous treatment records, previous assessments that were done. The idea being that you don't have to start over every time, and you don't have to ask people about themselves or have them do stuff to know things about them. We all have this kind of public trail, and if you have a conduct record from school, that might be meaningful data for a psychological assessment. If you've drifted from job to job to job, that's meaningful data regarding your level of impairment due to this abnormal behavior that you're exhibiting. Okay, so that's one of the simplest and easiest ways to get data, and everybody should be sure and do that if you decide to be a clinician. Okay, so we've talked about lots of different ways of gathering data. Now let's talk just for a minute, because we've probably been thinking about the level assessment at the individual level. So we think about, usually, most of us, unless you come from kind of an LMFT background, think of an individual presenting with a problem and assessing and gathering information about that individual. And that is frequently what we do. But often we also gather information about a couple or about a family. And when we do that, it's not just, a couple isn't gathering information about two individuals. It is that, but it's gathering information about two individuals and information about the couple, which is different than the two individuals. So when thinking about a couple or a family system, we want to know about the relation between individual characteristics. So in a couple, if one person is really dominating, is the other person submissive? That's important information. If they're both very dominating, domineering personalities, well, that's going to make for some fireworks. But usually we see the kind of complementary patterns. But we want to know that. We want to assess the match. How do these people fit together in terms of what you're like and what you're like, your individual characteristics? How do those go together? What's the dynamic? Another thing, depending on your theoretical orientation you may be interested in, are the attributions people make for other people's behaviors. So whenever your husband does this, whenever your wife does this, whenever your child does this, why do you think they do it? And it's not so much that you're looking for the answer to why they do it. You want to know why this person thinks they do it, because their attribution, their understanding of the behavior is important, because it will affect how they treat that person. And usually that's what we're working on, is how people are treating each other. Beyond that, we want to know about relational patterns. So how are people organized, especially like in this family? Is it mom and daughter against dad and son? Have you kind of split into two camps? Or maybe it's is it mom has recruited the kids to be in her camp and they're against dad, and dad's floating off by himself? What's the relational pattern here? Who's allied with who? You know, think about Survivor. Where are the alliances? Who are the enemies? When do these things? Has it always been this way? And then, you know, what's a healthy, functioning relationship pattern for this family system, or for this couple? And then we can even go kind of thinking more broadly, doing some assessment at the cultural level. And typically, the culture isn't our client, unless you're a very privileged therapist to be able to inform public policy. But when working with either an individual or a couple, you might be asking questions at the cultural level. So, what's the cultural context that this person exists in? And how do I figure out information about that, right? So how do you figure out about this person's socioeconomic status, their spiritual community, their level of family involvement? Yeah, well, very few standardized tools for that. So this is usually whenever you're going back to the good old clinical interview. Okay, so that's about it for assessment. Now let's move on to talking a little bit about diagnosis. Okay, so just like when we talked about why do we assess, let's talk a little bit about why we diagnose. Why do we have diagnostic categories and diagnostic procedures? A couple reasons. Primarily, it's for communication. Right? It's much easier to say, you know, this person meets criteria for major depressive disorder, than to say that, well, for a period of 2 weeks, they experienced feelings of guilt. More days than not, they experienced feelings of guilt, sadness. They cried. They had trouble eating. They've lost weight. They have difficulty concentrating. I mean, listing all of the symptoms, just saying they meet criteria for the disorder, and people generally having an idea what that means. Well, it saves a heck of a lot of time. So when providers need to communicate and say, okay, I'm passing off treatment from me to you, or I'm bringing you in, so maybe I'm a therapist and I'm trying to bring in a psychiatrist or a social worker or a family therapist and trying to give information about a client. One really quick way to provide a lot of information is to tell them the diagnostic label, you know, what things they meet criteria for. It obviously isn't the full picture of the person, but it is some information, and potentially meaningful information. It's also important for communication among researchers. So when people are trying to figure out why people act certain ways, and how do people who are struggling with certain problems get better, for us to all to be able to be doing research on and the same things, we need to be talking about the same things. So when talking about people struggling with feelings of depression or the loss of interest in pleasurable events, well, we need to be able to have these diagnostic labels that have clear criteria to say, okay, to be in this group, to be in this study, you have to meet criteria for this disorder, rather than everybody setting up their own criteria for, well, I think depression is this, so people in my study on depression had these criteria. Well, people in my study had these. No, everybody can say, no, you had to meet DSM-4 criteria. That way we all have kind of a same, the same rules are playing by, so that we're talking about the same thing, and research can move forward rather than pinging around from left to right. And then beyond that, it can be helpful for communication with clients. And sometimes this can be a really helpful thing for people just to have a label to apply to their experience. Say, oh, okay, now I don't feel crazy anymore. I know that the things that I've been experiencing, this is obsessive compulsive disorder. And I'm not the only one who has it, and I can read all about it on the internet, right? So in some ways it's empowering to get a diagnostic label to describe your experience, to kind of encapsulate some part of your experience that you're struggling with. So sometimes that can be helpful, sometimes not as much. So primarily we diagnose for communication, but secondarily, not secondary to some people, but secondarily for reimbursement. For whenever therapists, some physicians are treating people for problems, usually people can't pay out of their own pocket for that kind of stuff, so there's third-party payers, right? Insurance companies, and insurance companies aren't going to say, oh, well, somebody's having a problem getting along with their spouse. Sure, we'll pay for that. No, they're only going to pay for treatment for certain identifiable psychological disorders. And they have their reasons for that. But frequently, you can only get paid if someone meets criteria for a particular diagnosis, or at least some diagnosis. And that depends on insurance companies, but by and large, that's frequently the case. Okay, so we know about why we diagnose, and we know that there are these diagnostic labels, these diagnostic categories that are in the Diagnostic Statistical Manual of Mental Disorders, 4th edition text revision, right, written by the American Psychiatric Association. But where do the diagnostic labels that we have now, where do they come from? Well, we know that they, in America, it started back in 1840 with the U.S. Census, and there was a need to just classify individuals with different problems. And this is kind of and what the census was for then is what the census is for now. And if okay, there are this many people in these areas having these problems, so that the government knows where to shift the funding. Okay, there's a lot of people on the West Coast that have this problem, people on the East Coast that have this problem. Money for this needs to go here, money for this needs to go here. Right? So that's where it started in the U.S. And then the next big development was the publication of the Diagnostic Statistical Manual of Mental Disorders, which has undergone obviously multiple revisions, given that we're now with 4. So there was the first one, and then 2, and then 3, and then 3R, so a revision to the 3rd one, and then 4, and then a text revision to the 4th one, which no major changes, but just some changes in the wording of things. And the 5th version, the next version, is coming out in 2013, I believe. In the first book, a small little paperback little thing, 106 disorders, to now we're up to 297 disorders. So does that mean that there are more disorders now than there were when we first started? Yes and no. There are more diagnosable disorders. There aren't more problems. We've just found more ways to divide up the pie. It's the same type of problems. We've just gotten more specific. So we've gone from one diagnosis being neurotic to now, okay, well, different types of neuroses, things involving anxiety. We have generalized anxiety disorder, obsessive compulsive disorder, sociophobia, specific phobia, post-traumatic stress disorder. Right? We've got all these different types of anxiety rather than one kind of lump thing, and that's happened with other lumps as well. We've partitioned them into, okay, well, in this large category that we had, there's a lot of different people. Let's divide it up to make it a little more accurate. So in the course of developing the DSM, and as it's gone through changes, there's been a change in the nosology. And a nosology is a classification system for psychological phenomena. And there are a couple different ways you can go when developing a nosology. And the classical categorical approach for psychological disorders, it'd be where you would assume that every diagnosis has a single cause, and one set of conditions or symptoms is necessary and sufficient to be in the category. So if you have depression, there's one cause for depression, right? And depression is characterized by maybe 5 symptoms. And if you have all 5, you have depression. If you have 4 or 5, you don't have depression. And if you have 5 plus some other stuff, yeah, you still have depression. As long as you have these 5, this particular 5, then you have it. If you don't have those, then you don't have it. That would be your classical categorical approach. and that'd be one way to go, not the way that the DSM is currently written, but it's a possibility. A dimensional approach is another option. Really, two ways of doing a dimensional approach. One would be we still have these kind of categories, right? But category membership depends on how much of a given symptom, so a level on a dimension, how much of a given symptom or set of symptoms a person shows. And so if you we have these 4 dimensions of depression, and if you're high enough on all 4, then you're in. One way to look at it. Another way, more kind of radical way, would be to say do away with categories at all and just look at important dimensions. And so all people can be put somewhere on all dimensions. So you have these dimensions of psychological functioning, level of depression, level of anxiety, level of energy, level of confusion, whatever. And everybody is somewhere on the dimension. And that would be another way to go. And you would no longer have these diagnoses. You would have a label. You would have, oh, you have depression. You'd be, okay, on these 4 important dimensions, you're high. It would impair communication a bit, but it would be probably more accurate. And then there's a third approach, which is the one that the DSM currently uses, is a prototypical approach. And for the prototypical approach, we have these categories, right? A group. And there are essential characteristics for group membership. But they're necessary, but not sufficient. And other characteristics that are typical of some prototype, and there's enough similarity to the prototype, and you're in. So for depression, there's kind of this thinking that there are some symptoms that must be present. So, and for depression in the DSM, it's either sadness, depressed mood, or anhedonia, which is loss of interest in pleasurable events. You have to have one of those 2 things. Those are essential. And then after that, there's a list of symptoms. So of these 9 symptoms, you have to have 5, right? So there's kind of this prototype, there's this ideal, okay, depressed people are like this. They have these kind of 9 symptoms. But as long as you're close enough to the prototype, if you have 5 of those 9, you're good. If you have 4, not so much. If you have 6, that's fine. But you have to have a certain number. You have to be close enough to the prototype, to the ideal person with major depressive disorder. Okay. So just like we talked about with assessment, there are some issues in classification which should sound familiar. Reliability. And reliability for classification is in regard to the rules for inclusion in a group, so the rules for diagnosis. So one way to look at it would be reliability across clinicians. Does everyone get the same result when applying these rules? So if there's a client and they go to one therapist and they get diagnosed with generalized anxiety disorder, and then they go to another therapist for a second opinion, that other therapist, using the same book, using the same DSM-4, do they also diagnose them with generalized anxiety disorder, or do they diagnose them with no disorder, or maybe with major depressive disorder? Right? If they diagnose them in the same way, and that happens multiple times across multiple people, then that diagnostic category has good reliability. And different diagnostic categories have different levels of reliability. So things like schizophrenia has pretty good reliability. Most clinicians agree when somebody presents whether or not they have schizophrenia. Others, most notably the personality disorders, much lower levels of reliability. If somebody presents and one clinician thinks that that person meets criteria for narcissistic personality disorder, if there are 2 other clinicians in the room, neither one of them may agree with that diagnosis. They might come up with other personality disorders, and they may come up with no disorder. So the level of reliability differs across diagnostic categories. So we look at reliability across clinicians, but also reliability across time. So if the disorder is supposed to be stable, if you meet criteria, point A, do you also still meet criteria at point B? Would you still be diagnosed 2 weeks later if you hadn't really gotten any better? So reliability is important, but obviously more important would be validity. Those same kind of ideas with construct validity. So if you meet criteria for depression, major depressive disorder, then you really are depressed, if, again, assuming that's kind of a real thing, and that you're different in some way than people that meet criteria for other disorders. So there's kind of divergent validity where people in different categories look different, and they look different in the ways that they should look different. Right? And then two people that are both in the same category, two people that both meet criteria for major depressive disorder in some way are similar and have similar outcomes or responses to treatment. That would be the ideal for validity. Unfortunately, not really true for most categories. And then criterion validity. So again, knowing the diagnostic label, tells us meaningful information about outcomes. The course of the disorder, response to treatment. So people that meet criteria for major depressive disorder are more likely to have a suicidal attempt in the next 2 years, or have a history of suicidal attempts, or some behavioral marker that should relate to that construct. And again, the level of validity differs across diagnostic categories. Some are probably more valid than others, and there are lots of reasons for why there's some diagnostic categories of questionable validity still in the manual. Most of those reasons being social and political. Let's take a look at what the current system is. As I said, it's we have the Diagnostic Statistical Manual of Mental Disorders, 4th edition, text revision, and it's a multi-axial format. So it's really an attempt to go beyond just describing the symptoms, and in a way of the format allows for the inclusion of other information beyond just, okay, here's the symptoms of the disorder, but there's also room for other information related to whatever problem the person is dealing with. So the main kind of axes on the multi-axis system we usually talk about are axis 1 and axis 2. Axis 1 is where you have your kind of major psychological disorders. Originally thought of as state disorders. We think of state versus trait. State being something that's temporary. So, okay, you're experiencing major depressive disorder now, but it's not kind of who you are, and it could be temporary. It's just a state thing. So those kind of things would go on axis 1, and they were thought also to be ego-dystonic. So ego-dystonic meaning not how you see yourself. So I'm feeling depressed, and I'm not Eeyore. Well, I like being depressed, but I feel bad, and I don't want to be this way. That's originally how it was conceptualized. That doesn't necessarily fit with a lot of disorders, either one of these things. A lot of the axis 1 disorders don't necessarily seem to be very state-like. Some of them seem to be more trait-like, like generalized anxiety disorder seems to be a fairly anxiety trait-like disorder. People that have it report remembering being anxious children and go on to be anxious people most of their lives. And some of the disorders aren't even ego-dystonic. But again, traditionally, that was axis 1, axis 2 was traditionally thought to be trait disorders, things that were how you are. So what goes on axis 2 now would be mental retardation and any personality disorders. So everything else goes on axis 1 for the psychological disorders. So axis 1 is all the mood disorders, anxiety disorders, most of all the disorders of early childhood, with the exception obviously of mental retardation, sexual disorders, sleep disorders, eating disorders, psychotic disorders, all that, axis 1. Axis 2 is just mental retardation and personality disorders. So thought to be how you are, stable, and ego-systonic. So people with personality disorders, if you're kind of narcissistic personality disorder, the idea being that it's ego-systonic, so you don't feel bad that you're narcissistic. Like, oh, I think I'm better than everyone. I really hate that. It's like, no, I am better than everyone. Of course I am. You're stupid for asking me that question. So it's egosystonic. So axis 1, axis 2 is where the psychological disorders are diagnosed. And then the other axes are for other information. Axis 3 for medical conditions. And it's not just any medical condition you've ever had, but any medical conditions that might be related to an axis 1 or axis 2 disorder. And it could be related as a possibly contributing to the cause, kind of etiology, or affecting the maintenance of the disorder, or something that could affect the treatment of the disorder. So somebody that's maybe diagnosed with a somatic disorder like hypochondriasis. Right? So somebody who thinks that they're ill when they're not ill. You could actually have a medical illness and still have hypochondriasis. So you could have, let's say, a skin cancer, right? A melanoma, or no, it's going to melanoma. Let's say a basal cell carcinoma, something that's pretty easily treatable. But you think that that this basal cell, even though your doctor told you it's a basal cell, we can treat it with a cream and you're going to be fine, but you think that basal cell is indicative of some sort of systemic cancer that the doctors just haven't found because they haven't looked hard enough. You can still have hypochondriasis. That basal cell carcinoma is related to that your axis 1 disorder, so that basal cell carcinoma would go on axis 3. Axis 4, kind of an afterthought, it's seemingly in the for the DSM, but a really important axis for most therapists. The psychosocial environmental stressors related to axis 1 or axis 2. So again, anything that might be causative, maintaining, or affect treatment that's going on in your world. So somebody that's experiencing depression, whatever is contributing to the depression or inhibiting their treatment, they recently divorced, recently lost their job, those kind of things go on axis 4. Major life events that are influencing the problems that they're dealing with. And then axis 5, your GAF score, Global Assessment of Functioning, and this is at the front of the DSM. It kind of gives some guidelines for what the different numbers mean from 0 to 100. When you have, you're functioning really well, to down at the bottom, you need to be hospitalized. You're probably going to kill yourself any minute, or somewhere in between. So it's kind of both severity of symptoms and degree of impairment due to the symptoms. So those things together, trying to quantify that in some number. Although it's just up to the clinician's judgment what that number should be. Again, there's some guidelines in the DSM about that. Okay, so we have these labels. We have the system. Let's look at how good the system is working in terms of reliability. So, to what extent would using the system lead the same person lead to the same person being diagnosed with the same disorder by different clinicians, different periods in time? So that kind of test, retest, and interrelated reliability. How would you figure that out? Well, you could have a client go to lots of people. That would take a lot of time, though. So probably the easiest way would be to what most researchers have done: write up a vignette, write up a description of client problems, and then send that description to a bunch of clinicians and ask them, what do you think this person meets criteria for? And see if they agree or not. Again, like I said, depends on the disorder. For things like bipolar disorder, you get a kappa score of 0.81, a kappa of 1.0. Kind of think about 100% would be total agreement. 0.81 is kind of like 81% agreement. So that's high. Down to histrionic personality disorder, a kappa of 0.12, so very low agreement for that one. So the rules that people use for the DSM lead to the same decision most of the time for some disorders, but not for others. One of the reasons that some disorders have there's disagreement is because people think, okay, well, it's not this, it's this. And the reason there's confusion is because there's frequently symptom overlap. And symptom overlap happens whenever the same symptom occurs in more than one disorder. So somebody sees that the person's having difficulty concentrating, And one person attributes that symptom to major depressive disorder, and the other person attributes that symptom to attention deficit disorder. And it's a symptom of both disorders. A person might have both. They might have just one, or they might have neither. But the fact that the two disorders overlap might cause problems. And the more that two disorders overlap, the more likely it is that there's going to be disagreement about what somebody has if they have those any of those symptoms that occur in more than one diagnostic category. In terms of validity, so does using this set of rules lead to labels that provide useful information? Well, it kind of depends. We have to have reliability before we have validity, and again, some diagnostic categories have poor reliability. So for the ones that have poor reliability, they necessarily have poor validity. The ones that have better reliability have better validity. So in addition to the problems with symptom overlap, another reason we sometimes struggle with validity is the degree of heterogeneity within groups. So in terms of heterogeneity, we're talking about people that meet criteria for a disorder. If we put them in a group based on that disorder, if there are high levels of heterogeneity, then the people are very different from one another. And that happens because of the way we created the system. It's like with depression, if you have to have 5 of 9 symptoms, well, I think about 5 of 9. Okay, so 2 people, one could have, they could have one symptom in common, and then each have 4 unique symptoms, 4 symptoms that don't overlap with the other person. So their experience of depression could be very different, and that makes the group of people in that depression group very heterogeneous. And if they're experiencing different symptoms, then it shouldn't be surprising that there are different etiologies, different responses to treatment, and different outcomes. So because of the heterogeneity within groups, limited validity to many of the diagnostic categories. That's why a lot of the research that's done, they use those diagnostic categories as a starting point. It's okay, people to be in a study on depression had to have major depressive disorder. Further, they had to score this high on the Beck Depression Inventory, and they had to not have met criteria for this, or this, or this. Right? So they call people out of that group to get a purer group, so they can get a more homogeneous group, because it's easier to study homogeneous groups. Unfortunately, just using a diagnostic label by itself leads to a very heterogeneous group. So knowing that somebody has major depressive disorder may not tell you a heck of a lot about them, because there's lots of different ways to have that and to experience that. So what are the major unresolved questions about the DSM, things that they're still working on for the DSM-5? One would be this question about symptom weightings. One thing to consider is, instead of just this kind of 5 of 9 type thing, or maybe there are some symptoms that are more important than others. So if you have this symptom, then you only need 2 more. But if you don't have this symptom, then you need 5 more. Right? So should we give more weight to some symptoms than others because those symptoms are more prototypical of the disorder? Another thing would be to look empirically at the cutoffs, because the cutoffs for, okay, you had to have this many symptoms. You think, okay, well, they probably established that empirically. They found, okay, people that had 5 of 9 all looked very depressed. People that had just 4 were very different than those people that had 5. And I'd love to tell you that was the case, that they did extensive research to show that. But the process, especially early on, not so much in the most recent iterations of the DSM, but early on, the process was a meeting with a bunch of mostly older white men in a room smoking. That was the time. And they said, okay, how many criteria do you think we should have? You guys are all experts in the field. And some would say 3, some would say 4. Okay, let's have a vote. And they would raise their hands. And they determined these cutoff scores and the symptoms by this kind of democracy of the academic elite at the time, which is of questionable validity. So the cutoffs for the disorders are somewhat arbitrary. They're determined by experts at a given point in time, but how well that represents maps onto reality is a empirical question. It's a question for research. So maybe cutoffs should be different. Maybe higher, maybe lower. It's an empirical question. Another unresolved question is dealing with the issue of comorbidity. Now, comorbidity is when somebody meets criteria for more than one disorder. Right? And the question is, okay, if they meet criteria for more than one disorder, is it two disorders, or is it one disorder that has features of these two disorders, and we don't have a name for this one uber disorder? We don't know. But we do know that of those people who suffer from one disorder in their lifetime, over 50% will be diagnosed with two or more diagnoses. Right? And there are multiple reasons that this might happen. One might be because one disorder might in some way cause another one. Right? So if you have an anxiety disorder for whatever reason, if you're anxious for long enough, and that kind of affects your interpersonal world and your intrapersonal world, and you become isolated, that might eventually contribute to the experience of major depressive disorder. Right? So in some ways, pathology can cause other types of pathology. But again, it might be not one thing causing another. It might be that it's one big problem that's just getting diagnosed in more than one way because we don't have a broad enough category for this kind of broader problem that you're experiencing. Another issue is this idea of reification. Reification is treating an abstract concept as if it were a real thing. And we do that usually when we name something. So things like major depressive disorder. There is no such thing. Right? It's not a tangible thing. You can't show it to me. You can't prove it exists because it doesn't exist. Right? It's a label applied to a collection of symptoms that people agreed, okay, a lot of people seem to have this type of problem. Let's agree what behaviors, what thoughts, what feelings are the people that seem to have that type of problem, do they have in common, and then we'll apply a label to it. And that became major depressive disorder. And that's true of all the disorders. These aren't things. These are pieces of human experience that we've put in boxes to say, okay, well, if you have this part of the human experience, we'll call it this thing. Right? It's not a physical, tangible thing. Even though it may have physical, tangible correlates, it's not a thing. It's been reified. Which is a problem to the extent that we forget that we made it and we begin acting like it is some real thing, which can contaminate our perspective. And then the kind of last issue in terms of evaluating the DSM things they're still looking at is going back to that kind of categorical versus dimensional approach. And probably something we'll see in the DSM-5, not a full shift to a dimensional approach, but more emphasis on dimensionality and the level of severity of symptoms and the level of severity of impairment, and trying to disentangle those things to some extent, because they're not the same thing. Somebody could have very severe symptoms but not be impaired by them if they have lots of social support. Somebody else with symptoms that aren't that severe could have a good deal of impairment if they don't have a lot of social support. So we need to disentangle those things and get a better idea of where people are at on these continuums, rather than just the simple yes, no, you meet criteria, no, you don't. And the biggest problem with the yes, you do, no, you don't, are the people that just barely miss. Right? Oh, you don't quite meet criteria. Well, they don't quite meet criteria, but you might really be having a lot of problems. You just haven't exhibited this one other symptom yet, or we didn't catch that symptom in our assessment because we didn't use a valid assessment procedure. Okay. So that's about it for now for diagnoses. Now let's move on to talking about research. Okay, so before we can talk about clinical research, we have to talk just generally about the basics of research. Ideally, all of you would have taken research methods before this class, but that rarely happens. So I'm going to cover some of the basics. If you've already taken methods, this will be a repeat for you. Generally, we follow this kind of hypothesis testing approach. right? Where a hypothesis is a prediction about the relationship between or among variables. Ideally, a hypothesis is drawn from a theory, right? Because if we draw hypotheses from theories, then we confirm or disconfirm the hypothesis, and thereby support or fail to support the theory. And by doing that, we can advance theoretical knowledge. If we just say, "Oh, I kind of wonder this," and there's no real reason for wondering it, I'm going to go do a study. Well, then we have this kind of scattershot science, and we don't move forward. But if we have theories that we're saying, okay, yeah, this one's getting more valid, or less, we're moving in a direction. Or everybody's pulling on the same balloon, either forward or backward, rather than going all in separate directions. The basic format of a hypothesis is if, then, right? So in the if part is basically, if this theory is true, then comes this kind of observation part. If this theory is true, then we should see this in this situation. And again, ideally, a good hypothesis would be testable and falsifiable. In terms of testable, something that you can systematically and objectively measure. So if maybe I have a treatment that I'm using with clients, and I say that I'm very successful, and I say that the reason that my treatment works, what I'm doing with my hands is I'm realigning their chakras, which isn't dirty, it's a spiritual thing, realigning their chakras, and that's why my clients are improving. Now, you can't systematically or objectively measure chakras, this kind of psychic energy, right? So it's not a testable hypothesis, so science would say, well, we can see if your clients are getting better or not, but we certainly can't say whether or not your explanation is accurate. So it's not a scientific theory. It's of no use to us. Also, good if hypotheses are falsifiable. So an example, one that's not falsifiable would be that people who smoke were weaned either too early or too late. And so hypothesis drawn from Freudian theory, right, based on the psychosexual development. People in the oral stage, if you're weaned too early or too late, leads to frustration or over-gratification at the oral stage. There's no way to disprove that, right? People who are weaned too early or too late smoke. Well, what's early and what's late? And if it's not one, then it's the other. So whenever I'm looking at people who smoke, I'm always going to be right, because they were either weaned too early or too late, because there is no such thing probably as the perfect time. So I could gather data and always be correct and say, oh yes, look, all these people who smoked, all of them were either weaned too early or too late. If I can't be proven false, it's a useless hypothesis. So I want a good hypothesis. It's falsifiable, it's testable, it's in this if-then format. And again, it's about this relationship between or among variables. And variables, hopefully you know what those are. A variable is anything that can have more than one value, right? So variables and constants. Very few things are constants. The temperature at which water boils at sea level, that's a constant. The temperature at which water boils is a variable, right? Because water boils at different temperatures depending on altitude. Right? But if I put enough restrictions on it, then it becomes a constant. So most things are variable. Most things can take on different values. And typically in studies we look at variables that are either continuous or categorical. Continuous, it can take on any value. Categorical, it can take on finite values. So continuous might be looking at a client suffering from depression, number of times the client cried last week. Right? It can be 0, 1, 2, 3, 4, 5, whatever. Or maybe I can even measure the amount of tears spilled, right? 0 milliliters up to a liter, and anywhere in between. It would be a continuous measure. Versus a categorical measure of kind of the same thing, asking client, did you cry last week? Yes or no? No, there's no, well, a little. No, it's yes or no. So you're either a crier or not a crier. That would be categorical data. If I measured your masculinity and your femininity, probably measure them separately. So how masculine you are, how feminine you are, those are continuous variables. If we measure if you're biologically male, biologically female, it's generally thought of as a categorical variable, with some exceptions, obviously, but generally thought of it as categorical. So we have variables that are continuous or categorical, and then usually they're either measured or they're manipulated. Sometimes we do stuff to participants to see what happens. We give them therapy, right? Or we show them scary things, and when we're doing that, we're manipulating a variable. So if I give one group therapy and don't give the other group therapy, therapy is my manipulated variable. If I scare people, maybe I show people a scary movie. I show one a scary movie, one people a funny movie. Type of movie is a manipulated variable. And if I do that, if I show people a scary movie and a funny movie, I'm probably going to measure something like how much they laugh, how much anxiety they reported having, and that'd be my measured variable. So I'm going to measure something. I'm going to manipulate something. Sometimes I'll just measure and I won't manipulate. We'll get back to that in just a second. But variables are typically either measured or manipulated. Typically. Okay. So in terms of research design, generally it can be broken down into two types, and some exceptions to this. But generally, it's either an experimental study, and an experiment is when you're looking at a cause and effect relationship. Right? So, does A cause B? Changes in A, do they cause changes in B? And sometimes we'll do something to people to see if they change. So we're going to measure you at time 1, do something to you, measure you again at time 2, and see if you changed because I did something to you. Other times we'll get 2 groups, right, and we'll do something to one group and then something different to the other group, and then see if those groups are different based on what we did to them differently. So when we do that, we have independent and dependent variables. So independent variable is a manipulated variable, and a dependent variable is a measured variable. Right. So the independent variable, again, is the one that's manipulated by the experimenter. So the thing that I do to you, that's the independent variable. Type of movie, type of therapy, therapy versus no therapy. If I give you feedback, I give you a personality test, and then I lie to all the subjects, and I tell them either, oh, this showed you're a sociopath, or this showed that you're a kind and loving person. So I manipulate the feedback. I don't give them the real feedback. I manipulate it. So type of feedback is my independent variable, right? Because it's independent of what they do. I decide who gets what. We'll talk about how I decide that in a minute. But I decide that, and then I'm going to measure something, and the thing I'm measuring is my dependent variable, and it's dependent because hopefully, if there's a cause and effect relationship here, their response to that dependent variable will depend on what level of the independent variable they received. So how anxious you are will depend on what movie you saw. How bad you feel about yourself will depend upon what type of feedback I gave you. So the dependent variable should depend on what level of the independent variable you received or experienced. So, like I said, to manipulate the independent variable, the experimenter controls who gets what level, and to do it in a way that's experimentally valid, you need to use random assignment. So individuals are randomly assigned to levels of the independent variable. And random assignment is not random sampling. You don't have to randomly get names out of the phone book. But however you got your people to be in your experiment, right? If you're going to have 2 groups, you randomly assign people to one group or the other. And when you do that because the assumption is that the 2 groups are equal on the dependent variable before you do something to them, right? So if I randomly assign people to these 2 groups, and I'm going to show them these different movies and measure their anxiety level, the assumption is if I've used random assignment, the groups will be equally anxious at time 1. May not be true, should be true if I have large enough groups due to the laws of probability, right? Okay, so and then you'll do a couple of things. You'll exert experimental control and take research methods and you learn more about that. But generally, those are the key things for experimental design: random assignment and manipulation of an independent variable. When you do that, when you have a difference in the DV, the dependent variable, you can conclude that it was caused by differences in the IV, and you have this cause-effect relationship, and it's a beautiful, wonderful thing. hard to do in clinical research. So a lot of clinical research involves correlational studies. Now, correlational studies do not look at cause and effect. They look at the relationship between or among variables. When you look at two variables, it's between. So it can look at the direction and strength of a relationship. So we're not going to do stuff. We're not going to manipulate a variable, sometimes because it's unethical to manipulate people in certain ways or just not feasible. But if I want to know, okay, is there a relationship between spanking, number of times you were spanked as a kid, and how aggressive you are now? It's unethical and impractical for me to set up a longitudinal study to have parents tell parents, okay, I want you to spank your kid every day, and I want you never to spank your kid. You'll never get away with it. Never get that through an IRB, right, Institutional Review Board. Since I can't do it ethically, I just kind of ask people, okay, well, how many times were you spanked? And then I can measure how aggressive you are, right? So I'm measuring both variables. Right? I'm not manipulating either. There is no independent variable. And I can find out the direction of the relationship. So is there a positive relationship? Positive means that they co-vary in the same direction. So the more you were spanked, the more aggressive you were, and the less you were spanked, the less aggressive you were. So as one goes up, the other goes up. As one goes down, the other goes down. It's a positive relationship. Is there a negative relationship? As one goes up, the other goes down. So people who were spanked more are less aggressive. You know, it beat the mean out of them. Right? That's the thing. And vice versa, people who weren't spanked at all are very aggressive now. You know, is it positive or negative relationship? And then I can also tell statistically the strength of a relationship. If there's no relationship, then the correlation will be 0. It's like, so if I know how much you were spanked, I don't know anything about how aggressive you are now. The stronger the relationship is, then the more confident I am that if I know the number of times you were spanked, I can kind of say clearly how aggressive you're going to be. So it has to do with confidence in the relationship. Strong relationships, more confidence. One's more predictive of the other. So as I said, there is no independent variable, so we don't call them two dependent variables. We say one's a predictor variable and one's a criterion variable. And sometimes it's arbitrary which is which. Usually you have a theoretical reason for why you're going to label one predictor, one criterion. And the difference is the predictor is what you're predicting with. So if I know this, I'm predicting with my predictor that you'll be this. So if I'm with the spanking and aggression, probably thinking, okay, well, I'm going to predict aggression with spanking. So spanking is my predictor variable, and aggression is my criterion or outcome variable. That's the variable I'm predicting to. Right. So if I'm predicting how aggressive you are with knowing how much you were spanked, spanking is predictor, aggression is the criterion. Okay. So with correlational studies, which we have to use for ethical and practical reasons a lot, you can find out if two variables are related, but you cannot infer causation from correlation. There might be a causal relationship, but you can't be sure. You need experimental data or possibly some longitudinal data at least to be more confident about a cause effect. Two primary reasons for that you can't infer causation from correlation. One, directionality. So you don't know if A caused B or B caused A just because they're related. So like amount of time that a kid watches violent TV and how aggressive they are on the playground. Does watching violence on TV make them more aggressive? Maybe. Or is it that kids who are more aggressive enjoy watching more aggressive, violent TV? And it's making them watch more violent TV. We don't know. We don't know which way the causative arrow flows. If we do a correlational study, all we know is they're correlated. Now, if we assign some kids to watch violent TV and assign other kids to watch non-violent TV, and then look for differences in aggression, then we can figure out whether or not there's this cause-effect relationship going on. Okay, so directionality is a problem, and then the other would be the third variable problem. And the third variable says that, okay, just because there's a relationship between A and B, doesn't mean that A causes B or that B causes A. It could be that there's a third variable that explains the relationship. So there's a correlation between air temperature. I'm sorry. Or name of the third variable. There's a correlation between ice cream sales and violent crime. As ice cream sales go up, violent crime goes up. So does that mean that people get eat a lot of ice cream and get an ice cream headache and then get angry and go commit violent crimes? Or is it people that are committing violent crimes think, man, I'm glad I shot those people. I need some ice cream. No, neither of those probably. It's this third variable that ice cream sales go up in the warmer months as air temperature goes up. So as the air temperature increases, ice cream sales increase, and as air temperature increases, people become more violent and more aggressive, and so there's more violent crimes. So there's this third variable that explains the relationship between the other two variables. So because of those issues, directionality and the third variable problem, you cannot infer causation from correlation, even though people do it time and time again. But you won't do it. I'm confident. Okay, so we have those two basic designs, and there are some others we won't get into here in terms of like quasi-experimental research. Save that for research methods. But two major types: experimental and correlational. And using experimental correlational, you can use different methods for both of those. And the methods, and there are lots and lots of research methods, but some of the ones that are used in clinical research are the ones we'll talk about here. One would be case studies. This is probably one of the oldest forms of clinical research, and typically very kind of qualitative, where you're just kind of looking for some information about a client or a few clients and just describing it qualitatively. What are they like? What are the qualities of this person? And maybe relating it to theory, but usually not doing anything experimental, really, where you're manipulating them, and not even really doing much by way of correlation in terms of measuring a bunch of stuff. This is more observational research, and usually used to generate hypotheses about other people. But they've played a big role in clinical research. Sometimes because there just aren't a lot of people going around that have certain disorders. They're fairly rare, so it's hard to do a large study with a lot of those people. So a lot of what we know are based on these writings of some unique individuals that some people, therapists, and researchers have gotten to know very well, and they've written about them, written their stories. Another good source of data would be archival research. So looking at existing data, this could be case notes from therapy, medical records, school records. We talked about this before with assessment. So you can use those same kind of client records, not just for assessment, but also for research questions. You don't have to go out and gather new data. You can look at data that are already existing. Survey data, and when I say survey, I mean, yes, kind of manageable surveys, but also face-to-face, just giving people questionnaires to fill out. Ask people questions about these variables you're interested in, which usually when you do that, you're doing correlational research. That's probably one of the most common types of research done among clinical researchers. Finding, okay, do you meet criteria for this disorder? Or asking about the criteria for disorder, and then asking these other questions about family history or about how they think, how they feel, how they behave, to see if there's a relationship between these symptoms and these thoughts, behaviors, or history. The gold standard, however, in clinical research would be clinical trials, or looking at the effects of a treatment or treatments on symptoms or functioning, and those are two different things. Sometimes looking at both. And one of the important things to consider when looking at clinical trials is what type of control group do they use. And sometimes you'll just do kind of a pre-post, so you measure symptoms or functioning for the group before treatment and after treatment. So you're comparing each person in the group to his or her own self, so they're their own control groups. Sometimes you'll compare the treatment group to a waitlist group. So 40 people show up saying, okay, I'll be in this experiment, and 20 of them get treatment. The other 20 are on a wait list for 2 months while the study's undergoing, and you're just measuring stuff without giving them any treatment, which may be some ethical problems with that, and also some research problems with that. Or you might also see it where they compare some new type of therapy to some established type of therapy as the control group, and that's actually the best way to do it. Another approach that I think your book describes a good bit would be single case experimental designs, which are things that where therapists can kind of be researchers themselves to inform their own practice. But also, if they would write it up and put it in journals, it could inform other people as well. And when you do single case experimental designs, the key is repeated measurement. So whatever your dependent variable is, if it's severity of symptoms, frequency of symptoms, level of impairment, level of functioning, whatever, you're going to measure that multiple times. And usually you're looking, if it's an experimental design, you're looking at if a treatment works or not. And one way to do that is to use a withdrawal design, an ABA design, where you're going to be measuring the dependent variable. You're going to, before you start treatment, you're going to give the treatment, you do some intervention. Hopefully the symptoms, whatever, the severity will go down, functioning will go up, whatever, there's this change. And then you withdraw the treatment to say, okay, do they get worse again? If they do, then you've demonstrated you have control over the symptoms, and you have stronger proof of an effect of the treatment than if you just said, okay, we started treatment and they got better. Okay, that's good evidence, but better evidence to say, okay, and we took treatment away and they got worse again. Now you really demonstrated you made a stronger case for the cause-effect relationship. So the withdrawal design is a basic way. Some problems with the ethics of taking treatment away. One way to get around that would be to a multiple baseline design, which more than one way of doing this. But one way to do it would be to apply the treatment in different settings. So maybe somebody's having, you have a client that has panic disorders when they go to work, when they go shopping, and when they get in the car. And you have these kind of breathing exercises to help treat their panic disorder, but you only have them visualize doing it and only do the breathing exercises whenever they're getting in their car. And you keep measuring panic attacks in the other settings. So you have kind of baseline panic attacks in the car, baseline at work, and baseline going shopping. Those are 3 different baselines, and you're only going to intervene with one of them. And experimentally, ideally, they only get better on the one that you're working on. And if it works, obviously, then you go back and you start treating the others. So now I start treating this one, and now it gets better. Treat this one, and then it gets better. Clinically, you actually hope that that doesn't happen. You hope that treating one helps improve the others, and you have a generalization of the effect. But experimentally, you'd like them to only be affected whenever you target them, because that then again shows stronger evidence of a cause-effect relationship between the treatment and the dependent variable. Okay, so we've talked about different methods of doing clinical research, and talked about the basic designs. And there's some issues in clinical research that are unique in some ways to clinical research, different from other types of psychological research. In terms of internal validity, which is an issue for all research, and internal validity is applies specifically to experiments. The degree to which you're confident that differences in the dependent variable are attributable to the independent variable. So it's whether or not your cause-effect relationship interpretation is correct. And so you found a difference in your 2 groups, or from time 1 to time 2. How confident are you that that difference is due to the thing that you say it is, the independent variable of the treatment, or is it possibly due to chance, or is it due to some other thing that you didn't control for, some confound? So maybe you're comparing 2 treatments, and maybe one treatment that you really like compared to one treatment that you think stinks, and you find that the treatment you like worked a lot better, but in your experiment you happen to, people that were delivering the treatment that you liked were all well-experienced, highly trained therapists, and then people delivering the treatment you didn't like so much, you said, well, probably anybody can do that, I'll just get some trainees to do it. Okay, so now you find a group difference. People that got the treatment you liked, hey, they did really well. People that got the other one didn't do so hot. Is it because of the difference in treatment, or is it because of the difference in experience level of the people delivering the therapy? right? So now you have this other variable that differs across levels of the independent variable that affects the dependent variable, and that's a confound, and that's a threat to internal validity, and that's a problem. So we want to make sure that if we have two groups receiving treatment, they're as similar as possible in everything that happens to them, except for the key elements of the treatment. Right? And if we're doing pre-post, there isn't something else happening in these people's lives that can explain them getting better other than the treatment. Right? So if the Dow jumps 20,000 points and everybody gets super rich during the course of your therapy, not so sure that your therapy worked. Maybe people are just happy that they have more money in the bank. You have to account for those things. So internal validity, you have to think about that. External validity, so this is, again, assuming good internal validity. Internal validity is a prerequisite for external validity, but assuming good internal validity, and that the treatment is responsible for the difference you found, to what degree would that effect, the effect of the treatment, be seen with other people, other than people in your sample? And also, to what degree would it be seen with other slight variations of the treatment? So, do the exact therapists that did the treatment in your study have to do it all the time for it to work? You have to do it exactly the way they did it. Or will it generalize to more experienced therapists, less experienced therapists? Slight deviations from the treatment manual you used. So in your study, you showed with 10 sessions doing this, people got better. Well, what if you did 9? What if you did 11? Would it still work? Would you have the same effect? If so, then it has a high level of external validity. So to get good external validity, you could design a study that has all those variations and has an incredibly diverse sample. But that's expensive, time-consuming, and can lead to problems with internal validity. So my recommendation to you would be, if you're designing a study, focus on internal validity. Make sure that you're confident when groups differ, that's because of the independent variable. And then strive for external validity by doing more than one study. So I found that it works with this type of people. Now do another study with slightly different people. Or I found that treatment works when you do 10 sessions. Okay, now try to replicate the study. Do it again with 11 sessions instead of 10 sessions. And one of the things that we kind of have to keep in mind when thinking about external validity is, a book mentions the patient uniformity myth, which is the tendency to consider all members of a category as more similar than they are, ignoring their individual differences. So when we're interpreting findings, okay, the treatment worked. Well, if we find that on average patients improved, and that's good, but to what degree does that apply to everybody? Because it probably doesn't even apply to everybody in the study. Because we assume, well, if it worked, then everybody worked the same way. But if it improved on average, there may have been some people in the study that didn't improve. There may have been some that got worse. As long as there were enough that got enough better to offset it, the average moves up and we see overall improvement. But really people respond very differently, which makes clinical research incredibly challenging. Other things to think about, statistical versus clinical significance. Statistical significance has to do with that p-value. We won't go into a long, drawn-out discussion about that right now, but just kind of know that statistical significance is not significance. It's, okay, the group difference that I found is probably not 0, and that's all it is. It's not that it's wow, it's really big. It's really probably not 0. That's what statistical significance means. Whether or not an effect is clinically significant is a little harder to tell. Then we have to look at other things that frequently aren't published in research. Well, how much better did people get? When people got the treatment, were they able to go back to work? Did their lives get better somehow? That's what's clinically significant. So kind of keep that in mind when reading empirical work that talks about statistical significance. Say, well, okay, how big a difference did it make in people's lives? Is it meaningful? Last issue for clinical research, thinking about the ethical limitations that important that they're there because it's important to protect people's rights, but in some ways limits what we can know about therapy and abnormal behavior. One would be the kind of the problem I mentioned before about the control groups. There's some debate about the use of wait lists, depriving people of therapy for a period of time who might need it, and that may be unethical depending on what kind of problems you're dealing with. Or giving people treatment that you don't think is efficacious. Like if you say, okay, I don't think the standard treatment works, I want to test out this new one, so I'm going to compare standard treatment to the new one. If you don't think the standard treatment works, is it ethical to provide that to people? Another thing to keep in mind is the importance of informed consent. Excuse me. When you're working with abnormal behavior, psychopathology, you have to keep in mind that some research participants might be vulnerable, especially if you're going to ever conduct research in a clinic where you're working as a therapist, because you have some power over your clients. You know, they often look up to the therapist and may be fearful of disappointing the therapist, and so they may not have as much room to say no to participating in the study than other people. So there's some ethical concerns about that as well. In addition to the possibility of diminished capacity to give consent, depending on what type of psychopathology we're talking about. Okay, last thing I'm going to talk about research, almost to the end here. I know it's been kind of a long lecture, but looking at studying behavior over time, so in a developmental context, which is important especially for abnormal behavior for psychopathology, because it's not something that exists in a vacuum. It doesn't exist at one point in time. People got to where they are somehow, and they're going somewhere else. They're going to be different tomorrow. So it's important to look at how people change, how people differ across times. There are three major approaches to studying things across time. One would be cross-sectional designs, and this is whenever you're looking at differences across age groups. So you take a cross-section of society. So you'd go and you'd say, okay, people who are maybe with anorexia nervosa, who are 50, who are 30, who are 15, right? And measuring something about these three different groups to get an idea of how people differ at different ages in terms of their level of symptoms. One of the problems with cross-sectional designs is they can be influenced by cohort effects. So comparing these 50-year-olds to these 15-year-olds, the temptation is to say, okay, well, the 50-year-olds have lower symptoms, so these 15-year-olds, their symptoms will decrease over time. Maybe, maybe not. Maybe the 50-year-olds, because they're in a cohort together, they all came from one period of time, they were all in 5th grade together, right? Not literally, but they all went through the same experiences as they were children, and those are different experiences than the cohort that are age 15 now. And there may be something unique about that cohort that led them to have a lower level of symptoms than these 15-year-olds. These 15-year-olds might have higher symptoms than when they're 50 than these 50-year-olds, because they will experience different things. They will experience a different culture, different media. Right? So we can look at how people differ across ages, but we can't really look at the effect of age using cross-sectional designs. If we want to look at the effect of age, the effect of getting older, of maturation, a better approach would be a longitudinal design. This is where you get a group of people and you follow them across time. So you get the 15-year-olds now and you follow them until they're 50 and continually measure the behaviors you're interested in. But again, every design has its weaknesses, and for longitudinal designs you have to be careful of cross-generational effects. So this might be that the generation that you followed again might be different than others. So something unique about them. So even though for this group they got more or less whatever across time, and we're confident about that, but will other groups follow that same trajectory? Maybe, maybe not. So one way to deal with these problems is to do a sequential design, which is a combination of the cross-sectional and longitudinal. So you take a cross-section, you get the 15, the 30, and the 50-year-olds, and then you follow them all for 35 years or however long. So you're doing both things, and then you'll still have cohort effects and cross-directional effects, but you'll be able to tease those apart statistically if they exist, and to test if they're there. So that's the ideal, but incredibly expensive and time-intensive, obviously, to recruit that many people and follow them for any length of time and keep them in the study, keep them from dropping out. Difficult to do. Ideal, but not necessarily realistic. Okay, wrapping up, we've covered a lot of information about assessment, about diagnosis, and about research. I want to leave you with two kind of big picture thoughts. One, both assessment and research are continuous processes, right? And they're self-correcting processes. For both of them, you should be using this hypothesis testing model, and that's clear for research. Hopefully, it's clear also for assessment, where you go in and you're gathering data and you think, okay, I kind of think this might be true about this person, and then you're going to test to see is it true, is it disconfirmed, and you're going to look for, if you're a really good scientist, you won't just look for confirming evidence, you'll look for disconfirming evidence. Is there any evidence that my hypothesis is wrong? Let me look and see, rather than just looking, oh, let me see if I'm right. Got to look for both. And you go in with this kind of attitude of scientific skepticism. Because when you're certain that you know the truth, then you're no longer a scientist. Because at the heart of science is this doubt of, okay, I kind of think this is true. I'm going to gather some data to see. Okay, that kind of shows that it's true, but might there be another explanation for my data? Might there be some other way to understand this? Might the data that I gathered be unique in some way that isn't representative of other people? That's what science is about. It's about this constant search for truth, but never being quite satisfied that you found it. And I think the same should be said of assessment. If you gather some data about a client, you go, okay, I know exactly what this person is going on with them, and exactly how they're going to get better. I would really worry about the therapist that has that perspective, because no matter how good your assessment is, you're only getting a snapshot of the person, and it could be wrong. And you need to be open to revising your understanding, and the person is dynamic. You may have understood them exactly at the moment that you collected the data, but they may be different a week from now, 2 weeks from now, right? Something may have changed in their world, their relationship, in an important way that your former understanding is no longer valid. So be open to revising your understanding and continually assess, and realize that it's an ongoing process, not just, okay, you do assessment and then it's done and then you do some therapy. Okay, it's an ongoing process. The other thing, and I mentioned this, I just want to reiterate it because I think it's really important. Diagnostic categories are ideas, right? They're not things. We reify these categories because it's easier to speak of them as if they were things, but they're not. And you think, okay, well, depression, that's a brain disease, right? And yes, it is related to brain functioning, but so is laughing. Laughing is not a brain disease. And I can say, well, maybe somebody has hatred disorder. Somebody that has strong feelings of hate toward others they've never met. And so, if you're a Palestinian or a Jew living in the Gaza Strip, you may hate people you've never met. Perfectly good reason for it, probably, on both sides. But this strong hate, nobody you've ever met, and there may be this syndrome of behaviors related to that hate that I could easily measure and say, okay, here's people, and they hate these people, and then I could find people in other situations as well that hate people they don't know for whatever cultural, social, political reasons. but they have these strong feelings of hate, and they have certain behavioral markers. I could call it a disorder. And you know what? I bet you that we could probably identify differences in brain functioning when they're thinking about their hate and when they're not thinking about their hate, so it's biologically based. And we could probably give them medicine that would dull their feelings of hatred for a time, but it doesn't make this a brain disease, right? In these things, people often, I think, assume that things like depression, bipolar disorder, they have to be brain diseases. They have to be these things to be important. And then if it's not a disease, then it means it's either not important or maybe it's the person's fault or it's all on their head. And I don't believe those things are true. But I don't believe we have to force this other model, this kind of physical disease model, on these psychological problems in order to validate them and see them as things that are worthy of researching and treating and worthy of treating people with compassion. Okay, I'll get off my soapbox now. Assessment, diagnosis, and research. If you understand kind of the key concept of all these things, then you'll be in good stead as we start to begin to talk about the different disorders. And hopefully you're going with this kind of skepticism when we talk about, okay, well, this is what we know about this disorder. Think about, well, are you sure you know that? Because the answer in most cases is no, we're not that sure. It's our current understanding, and it may change. Okay, take care.